I'm a neurologist and sleep specialist. You're probably about to hear way more about sleep and sleep medicine than you've ever thought about, ever thought possible. MSA, of all of the neurological conditions out there, probably has the most sleep manifestations, and there are a fairly wide range of manifestations. So, without further ado, let's talk. So, four main categories of sleep disturbance that generally occur in MSA. You've got sleep breathing disorders, and we're going to go into each in a pretty significant amount of detail. You've got parasomnia, is the technical word for all of that crazy stuff that people can do in their sleep, ranging from sleepwalking, talking, fighting, driving, eating, etc., etc., etc. Just plain old sleepiness and insomnia. So first of all, breathing. We all do it. Doesn't always work all that well. In MSA, you have sleep apnea, by far the most common sleep disorder out there. It's kind of the poster child of sleep medicine. An apnea, what is an apnea? It's a pause in breathing, temporary. Breathing 99.9% of the time always starts up again. But a temporary pause in breathing occurring during sleep. It can be obstructive because the airway closes and you can't breathe through a closed airway. Or central because the part of the brain responsible for telling you breathe, 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 instead goes breathe, breathe, waits a little while, and then kicks back in. Then you've got stridor, which is significant. It's not just, it's scary for the bed partner, scary for the loved ones. What is stridor? We'll go into it in more detail, but in brief, it's a high-pitched sound, kind of a kind of sound. Can be present during both wake and sleep. Like I said, not just scary for the bed partner, it can have significant implications and require certain treatments. And hypoventilation, just shallow breathing. So sleep apnea first. As I said, pauses in breathing can be obstructive, it can be central. No matter what's causing you to stop breathing, if you're having temporary pause in your breathing, that's apnea. If it's obstructive, it's often followed by kind of a horrendous kind of sound. If it's central, the breathing tends to reinitiate in a little bit more of a quiet, gradual manner. It's very common, very treatable. Why does it matter? Few reasons. Both, if you're stopping breathing during your sleep, the way your brain starts you breathing again, it says, hey, you have to breathe, you're not breathing, wake up, you're choking, sends you a shot of adrenaline, your heart races for a second, your blood pressure spikes for a second, and you wake up, often so briefly that you're not consciously aware that you woke. To perceive yourself to wake in the middle of the night, generally your brain has to activate for about 3+ seconds, when often you have these very brief awakenings, so brief that the part of the brain responsible for forming new memories, the hippocampus, it doesn't really activate, you don't remember that you woke, but you're still getting dragged out of those deeper, more restful stages of sleep. So when you're waking throughout the night because of pauses in breathing, it disrupts the quality of sleep, it makes you sleepy, tired during the day, makes the sleep that you're getting less restful, because to be rested, you really need three things: quantity of sleep, quality of sleep, and timing of sleep. Besides the quality of life effects that apnea can have, those repetitive surges both in heart rate and blood pressure put significant strain on the body, on the heart, on the brain at times when it's less capable of responding to those demands because the oxygen levels are lower. So, increased risk of heart attack, increased risk of stroke, increased risk of hypertension. And while it doesn't cause these, it has absolutely been shown to worsen atrial fibrillation, diabetes, and cholesterol control. Not just a disorder of the overweight. There's this, not quite a misconception, but not quite, we'll go with misconception. There's a slight misconception that sleep apnea is a condition of the obese. And sure, there's certainly some truth to that. Elevated weight is by far the highest risk factor for sleep apnea, but there are plenty of people who are rail thin or very normal BMIs who have significant sleep disorder breathing just because either they were born with a jaw structure with a chin that's set back, which pushes the tongue back and narrows the airway in that manner. They were born with a high arch palate. They were born with a big beefy uvula like this person right here, or big tongue, or low-lying soft palate. There are a lot of very normal anatomic variations which can cause significant breathing problems during sleep, even in someone who has a very normal weight. So what are the signs and symptoms? You've got snoring, you've got snorts and gasps. The bed partner sees you stop breathing. That's a pretty clear sign that you're stopping breathing. Multiple awakenings. Whatever wakes you up, doesn't matter what it is, whether it's garbage truck outside, whether it's a breathing problem, whatever it is, your brain does a quick mental inventory and checks, okay, there's no pain, but you know what? My bladder's kind of full. That must have been what woke me up. So you go and do your business, go back to bed, fall back asleep, and the cycle repeats 3, 4, 5 times throughout the night. When actually, it very well may have been an apnea that woke the person. They woke. By the time you're consciously awake, your breathing is completely back to normal. So I think must have been that, when in actuality, if you hadn't stopped breathing, you would have slept through the night, but woke with a much more full bladder, but with much more continuous sleep. Non-restorative sleep, morning dry mouth, sore throat and headache, and daytime sleepiness. What do we do about it? Well, the gold standard, the longest used treatment is really CPAP or BiPAP, which is, it's pretty much an air pressurizer. It's a little machine, looks like this guy here, sits by the bedside, and it takes some of the room air, pulls it into it, puts it under pressure. That pressure goes through a hose that goes to a mask that you wear while you sleep, goes down your airway, and really just holds things open, almost like the support beams in a mine shaft. Now, my usual spiel is this. Nobody wants to sleep with a mask on. Nobody does. But if you've been tired, if you've been waking throughout the night, and wearing a mask lets you sleep through the night, it lets you wake feeling restored. For other reasons, there can be significant survival benefits, which we're going to go into. Wearing a mask is really the least of a lot of evils. And really, there are plenty of people who love it and can't sleep without it. I tend to be very honest with people. There are plenty of people who hate it and just put up with it as a necessary evil, but there are plenty of people who love it, and there's really no predicting who's going to take to it. I have many, many men, usually men because we're complainers, dragged in kicking and screaming by their wives saying, I'm just going to try it to get her off my back. There's no way I can use this thing. And they do great. So there's really no predicting. Plus, machines these days, it's not the CPAP of the 80s and 90s. They're small, they're quiet, they're way more quiet than most of the snoring. The masks are small, they're little tiny pillows ones that just go up against the nose. They work just as well as these big full face, so plenty of options out there. There are other things, there are mouthpieces. Weight loss can certainly help if it's weight related, but that's kind of a much longer conversation for another time. Okay, Stridor. This is the serious one, the very serious one. So it can be during both wake and sleep. It's a high-pitched sound, a kind of sound. Usually starts during sleep, but can certainly occur during wake. There are a few different theories for why it happens, and there's probably some truth to all of them. The two predominating ones are either that there's some weakness in the abductor muscles of the vocal cord, the muscles that spread the vocal cords apart. And so if they're not being spread apart, or at least if their muscles holding it open are weak and not spreading it as well, those vocal cords come together and they don't open as much, and it can significantly narrow the airway. The other theory is that there can be some dystonia, some overactivity of those muscles causing them to spasm together too, and there's probably a little bit of truth to both primary theories. It can be serious, because if you can imagine, the more wide open your airway is while you sleep and during the day, probably the better off you are. Because we're really suggesting weakness of the vocal cords, it often starts unilateral, starts on one side, but it can become bilateral, and by the time it becomes bilateral, it can be very serious, because what can happen is they can get to the point where they actually spasm together, and it can completely block the airway, and it's life-threatening and potentially fatal. So especially once it occurs during the day, that's suggesting that not just during the day, but during wakefulness, that's suggesting bilateral. It has to be addressed, and it has to be addressed quickly. So what can we do about it? CPAP, because, well, what does PAP do? It puts air pressure down the airway to hold the airway open. It holds that airway open, holds the vocal cords open, keeps you breathing. It works. It can have, treating stridor can have significant survival benefits. And we're talking not just months, we're talking potentially years. So if stridor is there, especially during the day, but even at night, talk to your doctor. Please, please talk about treatment, because it's not just scary for the bed partner and for the loved ones. On top of that, if CPAP is an option, or if it's present during the day, if it's bilateral, then sometimes, in fact often, we consider tracheostomy. For those who do or don't know what tracheostomy it is, it pretty much involves putting a little small hole right here in the airway. Sounds like a big thing. You breathe through the hole. Sounds like a big thing, and it is. It's a small procedure, but it's not a small step to necessarily take. But again, it's really the lesser of two evils because especially waking stridor can be very, very serious, and this fixes the problem, period. So if there's stridor there, if you haven't mentioned it to your doc, because often these things that happen during sleep, we don't really, more focused on the things during wake, they can kind of be pushed aside a little bit. Talk to your doctor, especially if it's during wake and on a soon basis. Okay. So the more interesting things, parasomnias, those kind of crazy things we do during sleep, ranging from sleepwalking, talking, driving, eating, cooking. Sleep murder exists for what that's worth. There are two major categories of parasomnias. You've got just like there are two major types of sleep. You've got non-REM, which is your non-dream sleep, and REM sleep. Most of the things that people conventionally think of, sleepwalking, talking, driving, eating, etc. You can tell I say that a lot. Most of those are non-REM parasomnias. The person's actually not dreaming. Their brain is sleeping nicely. It's just their body's off doing crazy things. People with MSA and other conditions, but especially MSA, often have the other type. It's called REM behavior disorder, a REM parasomnia. REM stands for rapid eye movement sleep. That's the phase of sleep where most dreaming occurs. And that's true dream enactment. Now, REM behavior disorder is often kind of the canary in the mine shaft of neurological dysfunction. It, along with decreased sense of smell, are the two symptoms that can often precede the onset of the neurological condition by approximately 10 or more years, actually. The three major disorders that are often linked with REM behavior disorder are MSA, idiopathic Parkinson's disease, and dementia with Lewy body. So it really can be a red flag that something's coming down the pipelines. It's becoming increasingly recognized in younger people. For whatever reason, it's really not well understood. More women than men. Often SSRIs, which are a very common antidepressant medication, can trigger REM behavior disorder. And interestingly enough, once it occurs, sometimes it doesn't go away even when you stop the medication. Now, there are also SSRIs. They stand for selective serotonin reuptake inhibitors, things like Prozac. You have me on the spot, so I'm blanking. Thank you. Yep, exactly. You got it. Yep, most of the antidepressants that are commonly used these days. It's a rare side effect, but it can definitely happen. So yeah, and now I was speaking with someone just a little while ago and saying, oh, we used to joke about it, and then it became serious, and it is. It's interesting. It's kind of saying, oh, those things mom and dad are doing at night, etc. But it can be dangerous. People have significantly injured themselves. They've injured their loved ones, their bed partners, due to these behaviors. When it first starts, it can be just little kind of herks and jerks and just little kind of quick high velocity movements. But as it progresses, it can become much more complex things. I had a patient who was dreaming about an intruder attacking his wife, and he was dreaming about choking the intruder. Well, the person he was choking was his wife, and everyone was fine, but it can be dangerous. Multiple episodes throughout the night. It's not just the bed partner who's at risk, the person can be affected as well. If someone falls out of bed, there can be significant risk for injury, whether it's breaking a bone, whether it's cracking the skull on a nightstand, on something on the floor. It's more than just a little bit of kind of that crazy thing that people do at night. In fact, and it's common, 33 to 65% of patients have had some harm, whether it's to themselves or their loved ones, bed partners, etc. Common. 70% of patients with MSA have REM behavior disorder, RBD, to some degree. Older data suggested about 38 to 65% of patients who develop it 10 years plus down the line have the risk of developing one of those conditions I mentioned. Newer data, as we start to longitudinally follow patients with those conditions and with idiopathic RBD, have shown that those risks are much higher than previously thought. As you continue to watch people, it becomes almost a an eventuality rather than a question that someone with REM behavior disorder has a high risk of developing one of these conditions. 33% at 5 years, 75% at 10 years, and once you get out towards 15 years, you're looking at upwards of 90% likelihood. And that's from onset of the dream enactment to the development of the neurological condition. Treatments. So someone's doing it. What do we do about it? Treatments exist. They work fairly well. The classical treatment was a class of medications called benzodiazepines. These are your Valium, Xanax, Klonopin, et cetera, et cetera, et cetera. They work not, they're traditionally anti-anxiety medications, sedatives, anti-epileptic medications. They don't just work by sedating the person to sleep. They actually help to restore the paralysis that's supposed to be there when someone's dreaming, that's faulty in patients with REM behavior disorder. So they actually do help to restore that paralysis to at least some degree. And they work well. The problem is that they're sedating, they're habit forming, although in this case, if someone needs it, they need it, fine. But the biggest issue is they're sedating, they can cause gait unsteadiness, they can cause daytime sleepiness, which can be its own problem in MSA. So really, in someone where there may be gait dysfunction already, you really want to consider starting a medication which can further exacerbate gait dysfunction with a lot of, kind of with a grain of salt. But the good news is that there's some new evidence that melatonin, which many of you have probably heard of, perhaps have used as kind of a natural supplement sleep aid. Your body makes melatonin and uses it kind of its own personal trigger as to when you're supposed to start to get sleepy and go to sleep. Melatonin has actually been shown in a study at the Mayo Clinic about 6 years ago to be almost as effective as clonazepam, the traditional benzodiazepine that's used. In fact, upwards of 60% of patients will respond equally well to melatonin as they do to benzodiazepines. Melatonin, while it does still have some risk of next day sedation, gait unsteadiness, etc., the risks are much lower than with the benzodiazepines. So in my patients with REM behavior disorder, I always start with melatonin unless it's really, truly flagrant to the degree where I'm extremely concerned about them and just want to get them treated as reliably as quickly as possible. But the vast majority of the time we start with melatonin because there's a 60% chance that it'll work and work equally effectively as the benzodiazepines. So we usually start at 3 milligrams. The study that I mentioned, they use 3, 6, 9, and 12 milligrams. So usually what I tell the person is start at 3 milligrams because if you go to the pharmacy, you can find melatonin anywhere from 0.5 to 10 milligrams. Generally, I tell the person, get a 3 milligram dose, start there, give it a week. If it's not working or it's working incompletely, things are better but not perfect, then I tell them start to titrate upwards. You go to 6, go to 9, go to 12, give it a week each time. You don't want to make any decisions based on just a few days of treatment. And really, the only thing that you really watch out for is the development of any of those side effects, daytime sleepiness, next day sedation, unsteadiness, etc. If someone hasn't responded by 10 to 12 milligrams, it's not that you're particularly dangerous going higher. It's just if you haven't responded by that point, they're not going to. Okay. Well, we've plenty of time for questions at the end, though. Okay. And then we've got the non-benzodiazepine sleep aids. Those are your Z drugs, your Zolpidem, Zaloplan, Ambien, Lunesta, Sonata, yada, yada, yada. Those, they really do two things. They do suppress REM sleep a bit. So the less dreaming that you do, the less dream enactment you're going to do. That's a little bit of a lesser effect. More than anything else, they do just tend to sedate the person through it, to be perfectly honest. So it's not a perfect option. They have their own side effects, paradoxically. While they can be used for the REM parasomnias, they often have a significant risk of causing the non-REM ones, the sleepwalking, talking, driving, eating. So they're really kind of a last-ditch resort. I never use them. Some people do, but it's out there. Okay, and I think I covered all this already. Let's see. Take-home points for REM behavior disorder. It is dangerous. First step, I've been talking about the medications. First step, bedroom safety. Whatever's next to the bed, whatever the person could fall out of bed and potentially hit, get it out of there. Nightstands, lamps, boxes. I had a patient who brought her in for treatment was she fell out of bed, caught her eye on a box, did significant damage to the orbit. So bedroom safety is by far the most important thing. And that's the thing about this is RBD, it's very treatable. We just need to take it seriously and treat it. But bedroom safety, bed partner safety, make sure that their bed partner is safe. If it's significant, while it's treatable, and our goal is to get it treated, and we almost certainly will, get the bed partner out of there until it's treated, because the last thing we want is something to happen to the spouse. Specific interventions, what can you do? So mattress on the floor, get them down to the floor level, at least that way if they were to roll off the mattress, you're falling 6 inches instead of 2 feet. Mattress corners, moving furniture, padding the furniture, anything that they could hit. I used to practice in Minnesota, a lot of guns in Minnesota. Get the gun off the nightstand, get the knives. Well, I don't know why would anyone have a knife near the bed, but if someone has knives near the bed, get that out of there. Exactly. Restraints. I've had patients who tie their loved one down. I'm not kidding.
Oh, yeah.
I'm not going there. During sleep, you really want to avoid restraints because it's possible for them to get twisted around. You know, just imagine their arm is tied down, but they're falling out of bed. You could damage the shoulder. Restraints aren't a great idea. Side rails, kind of the jury's out. They're probably a good idea, but there are people who've been caught between the rails and can cause injury in that way, so it's not a perfect option. But there are options out there. Mostly, keep the person safe, keep the bed partner safe while it's getting treated, and mention it to your doctor because, again, it's very treatable and it can be significant. I do not, unfortunately. Fatigue versus sleepiness. So 50+% of patients with MSA are tired during the day, whether it's fatigue or sleepiness. Terms often used very interchangeably. I'll give you my quick, terrible acting description of the two. So sleepiness, you're tired, your head is heavy, your eyelids are heavy, you want to close your eyes, and if you did, you would fall asleep. That's sleepiness. Fatigue, your body's heavy, you don't have the energy to do what you need to do, you don't have the strength to do what you need to do. Maybe you want to take a nap, and if you did, maybe you'd fall asleep. Maybe you just rest with your eyes closed, but it's not the same overwhelming force that is sleepiness. Now, that's a rough idea of the difference. Honestly, often, in fact, overwhelmingly, people have a little bit of one, a little bit of the other. There are actually gender differences in presentation of sleepiness. Men tend to be more classically sleepy, falling asleep in their chair, whereas women tend to be more fatigue-like in their presentation of sleepiness. So it's kind of a rough indicator of what's going on. The reason why it matters is there are different things that cause sleepiness and different things that cause fatigue. Sleepiness, the differential, the possible options out there is actually very limited. Like I said, it's quantity of sleep, quality of sleep, or timing of sleep. Fatigue, unfortunately, that can just come along with a lot of things, whether it's depression, whether it's the disease itself, MSA, whether it's anemia, thyroid dysfunction, etc. The list goes on. But often very treatable. What are possible causes? Sleep disorders. We already went through the sleep breathing disorders. There are other sleep disorders out there. People who, for instance, kick their legs throughout the night, which wakes them up. Medication-induced sleepiness. Narcolepsy. The media depiction of narcolepsy is the person who falls asleep walking down the street, falls asleep in their soup, falls asleep in conversation. Most narcoleptics are not that sleepy. Most narcoleptics have just been tired for most of their life and just assume this is how everybody is. But the area of the brain responsible for narcolepsy is very close, in fact, adjacent to the areas that are affected in MSA. And so often that area can be affected as those populations of brain cells degenerate. And so often secondary narcolepsy coming from the condition itself, can occur. So the sleepiness and narcolepsy, it's symptomatic treatment, but it's treatable. So the tiredness, the fatigue, the sleepiness is not necessarily something that just has to be lived with. Okay. And in terms of treatment, we're talking when patients come to me sleepy with this type of condition, we make sure that there's nothing else going on. If there's not anything else going on that's causing sleepiness, we treat it. If it's medication induced, we look at the medications, make sure that there's nothing that they're on that they don't need to be on, minimize the dosing of sedating medications, and if it's narcolepsy, we treat it with medications to help the person stay awake. Okay, insomnia. Last one we're going to talk about. So, insomnia has three major manifestations: difficulty falling asleep, difficulty staying asleep, and end of the night awakenings, where you wake up 2, 3 in the morning, and that's the end of your night. You just stare at the ceiling for the rest of the night. And there are different things that cause each. There are different interventions for each depending on what's causing it. So, what's the first thing that we do? Sleep hygiene. These are all of those kind of bad maladaptive habits that we all fall into when we've either been starting to become tired, and we've started to sleep poorly, that just perpetuate the problem. We're talking about my personal favorite, caffeine, which I'm a huge fan of. I'm an absolute caffeine addict, but it's got its time and it's got its place. That time is not after about 2 or 3 in the afternoon. Now, that said, if you can have a cup of coffee and go at 9 p.m. and jump in bed at 10 p.m. and fall right asleep, is it the worst thing in the world? Maybe not. There is some evidence it might lighten your sleep and deteriorate a little, cause a little bit of a deterioration in the quality of sleep. But again, if someone's sleeping well, falls asleep nicely at night, and has caffeine in the evening, more power to you. If not, if you're drinking that caffeine cup after cup after cup just to fight through the sleepiness that you're experiencing because you're not sleeping at night, then that caffeine has to be limited. Napping, same thing. You're exhausted, you slept poorly, you want to get some sleep. I slept 3 hours last night, I'm exhausted. If I'm going to get it, I need to get it now. Don't. If at all possible, don't, because there's a chemical in your brain called adenosine throughout your body. So there's a lot of different functions throughout your body. In your basal forebrain, or right up here at the front, your brain uses adenosine to tell itself how tired you should feel at any one time. The more adenosine there is, the more sleepy you are. The less adenosine, the less sleepy you are. The longer you spend awake, the more adenosine builds up. Your brain makes it. The more time you spend asleep, it breaks it down. That's actually how caffeine works. Caffeine tricks your brain into thinking that there's not as much there as there really is. Here's the problem. When you go to bed, you want nice high adenosine levels because you've been awake for a while. Every time you nap during the day, your brain's breaking it down, breaking it down, breaking it down. So when you're going to get in bed at night, if you spend a long time awake, that adenosine levels are nice and high, it'll fuel you to sleep. If you've been awake or been napping throughout the day, levels are low, you don't have that same adenosine burden to help fuel you to sleep that night or to keep you asleep at night. Clock watching. I'm going to use a little bit of hyperbole here. There is not a single person in the history of humanity, there is, but for the sake of the point, there isn't, who has fallen asleep faster knowing what time it is, and it's just frustrating. Looking at that clock, say, it's 2, it's 3, I have to be up in 4 hours, I'm going to be exhausted if I can't fall asleep. It doesn't help you fall asleep faster, and it's just frustrating. Alcohol or nicotine. Often people will use alcohol as kind of a nightcap to help yourself fall asleep. 1 drink, maybe. Anything more than 1 drink, though. Alcohol has 2 effects. Its initial effect is a nervous system depressant. It helps put you to sleep. It shuts down your brain, your nervous system. After about 4 to 6 hours, it switches over, and instead of becoming a depressant, now you're just left with stimulant effects. And that's why if someone has more than a drink or 2, often the rest of the night is spent waking frequently throughout the night. The sleep that you're getting is much less continuous, it's much less restful, it's much shallower. Nicotine, often people who are habitual smokers will say, I have my cigarette because it relaxes me. Well, yeah, but it actually, besides the general relaxation feeling, there can also be a stimulant effect to that. And while there's relaxation, there's also alertness that comes along with it. Bedroom environment, often people sleep better more continuously in a cool, clean environment that doesn't have train tracks outside, etc. Okay, good habits. So, worry time. If people find that it's often the active mind, the brain racing, you can't shut it down, that's keeping you awake at night. Setting aside maybe half an hour of worry time before you get in bed to say, okay, you know what? This is what's on my mind. Take a pad and paper, write it down. I have this going on this weekend. I have to do this, that, and the other thing. I have this tomorrow. Write it down. Put your plan on paper. Your brain, your subconscious knows it's been addressed. It knows that it's handled it. It doesn't have to sit there and perseverate to keep going over it. It's not a magic fix, but it can certainly help to quiet the mind down. Exercise. While exercise before bed isn't a great idea from a sleep standpoint, Any exercise during the day is better than nothing, and one of the most important things you can do to sleep more deeply and longer and to help initiate sleep is regular exercise. Bedroom temperature, like I said, nice and cold. Mental distraction techniques. Counting sheep doesn't work. It's too easy. If you're really worrying about this, that, or the other thing, sitting here counting 1, 2, it's too simple. There's too much mental headspace left. So often what I'll do is pick a high number, say 4,972, and start counting backwards by, say, 7s or 3s or what have you, and start to count back. And it's a much more complex mental task because you have to think, okay, what was that first number? Okay, what's the math? Okay, what's that next number? And start going backwards. And there's not so much mental headspace left to worry, to kind of go over things, and it's boring. Don't worry about the math. If you're someone who's going to say, oh, did I get that right? And really it's going to be more frustrating. Don't worry about it. It doesn't matter. Now, medications. What are there? There are medications for sleep. They're often overused, but they do have their place. What are the older ones? Well, you've got your supplements, you've got your melatonin, valerian root, chamomile, and they can certainly work. It's highly variable how someone responds to any of these things, whether it's a sleeping medication or a supplement. Some people respond beautifully to very low doses of something very benign, like, as I said, valerian, chamomile, melatonin, etc. Some people, sky-high doses of significant prescription sleeping aids doesn't touch them. So there's a lot of trial and error. There's a lot of really fine-tuning and experimenting and finding the right regimen for the individual person. You've got the benzodiazepines, those kind of older anti-anxiety medications. They can be habit-forming. They can cause some unsteadiness, and sedating antidepressants. You've got your newer ones, which are your Sonata, your Ambien, your Lunesta, and some other ones, even newer ones, which are even safer from a side effect profile. Generally, from a medication standpoint, if you're going to go with a medication, the newer agents are safer. They have less side effects, but they're still, they have their drawbacks. Now, there's a ton of research out there comparing behavioral to interventions, non-medication interventions for sleep to the medications. And generally, they each have their place, but the non-medication interventions generally work better in the long run. They have less side effects, less tolerance, less dose escalation, all the things that can happen with sleeping pills. But they take time to work. So often, we'll use them either in combination or individualized based on the person. What behavioral options are out there? Relaxation training, mindfulness is excellent, meditation before bed, and a wide range of things. The most, by far studied, the most used range of techniques for sleep from an insomnia standpoint is something called cognitive behavioral therapy, CBT. And what CBT does is it aims to reframe the way the brain approaches a problem. Often people who've been dealing with insomnia for a long time will approach the bed in the bedroom with almost kind of a catastrophization, which I don't even know if that's a word, but I've made it up and I'm going to stick with it, where you really worry, okay, you don't go to bed with this thought of, okay, this is my bedroom, this is my sleep place, it's calm, it's relaxing, this is where I fall asleep. Often people approach the bedroom with this kind of fear of, here comes another night, I'm not going to sleep, I'm going to lie in bed awake, I'm going to fight to sleep. The bedroom is associated with a frustration to sleep, all of which just defeats the whole purpose, because at that point, your body's revving up its fight or flight response. You're not going into that nice rest and digest mode, you're going to that fight or flight, and the more your body revs up to fight, the less likely it is you're to sleep. And that's really what CBT aims to do, is to reframe that problem. So, there you have it. Thank you very much for your time and attention.